Thank you very much. And as alluded to in the previous session, one of the ways to bridge gaps is through education. Our next session is on addressing disparities through open supported learning. To take the session, we have Dr. Rebekah Zechariah, who's the head of the Distance Education Unit in CMC Vellore. Dr. Rebekah completed her undergraduate training here in CMC in 1999, following which she served in the Bangalore Baptist Hospital for a couple of years. After her marriage, she joined her engineer husband in the United States, where she completed her MD in internal medicine in St. Louis. Recognizing the need for further training, she trained in geriatrics. And it was while she was doing this that she also completed a master's degree in education in the University of Wisconsin. Dr. Rebekah and her husband Arun returned to India in 2015, and she has been working in the distance education unit since then. She's been involved in starting several of our need-based blended learning courses that are delivered through the distance education unit in CMC. And right from the stage of conceptualizing the course to the curriculum development, content creation, course delivery, as well as leading, equipping, and supporting the team. Her husband Arun is the head of education technology in CMC, and they have 2 children. So Dr. Rebekah, over to you to talk about the bridging the gap through addressing disparities in open supported learning.
Thank you so much for that kind introduction. Good morning, everyone. Thank you for this privilege and this opportunity. I have developed a sore throat since last night, so if I sound hoarse, please forgive me, but let's hope we can get through the presentation without much problem. So I've been given a topic that is very interesting, and I'm so glad that in a conference such as the Medicine Annual Conference, as we're looking at equity and access, we are thinking about open and supported learning, which is really the bread and butter of the work that we are involved in the distance education department. Before I actually address a few disparities, I actually want to take us through a few questions that will help us be on the same page as far as what we know about open supported learning. And I think those 2 words have kind of been put together, but I'd like to kind of break them apart and take them one at a time. So what do we actually mean by open learning? I like definitions a lot, so I'm going to just look at one definition, which says that open learning is the term that is used to describe situations in which learners have the flexibility to choose from a variety of options in relation to time, place, instruction methodologies, modes of access, and other factors related to their learning processes. Now, it's a large definition, but really, if we just look at a couple of words which I've highlighted in a different font color, the idea of it being flexible and the idea of having options to choose from. I think that is key when we think about open learning. Right now, actually, if we look at the schooling system in our country, there's a lot more openness to open learning. The homeschooling system, the open school, there are a lot more children in our own country. It used to be a thing of the West, but in the last probably 10, 15 years, there have been more avenues, especially in the larger cities, where parents are actually choosing to put their children through a homeschooling system. But that wouldn't really be possible if we didn't have a body that kind of recognized it and accepted that as a way of education. So the National Indian Open School, NIOS, is something that children can actually enroll into and then take their exams and then actually get into mainstream, whether it's writing NEET or whatever else it might be. So that, in one sense, is encouraging that even before higher education, the open learning is available now for those who would choose it. And especially for, I think, children whose families have to transfer a lot and keep moving schools, or children with special needs, this is a good and a viable option. So that is basically, if we think about, open learning even before we get to the higher education process. But we are all sitting here as medical professionals, probably a few other careers as well. So we need to really look at what is the relevance of open learning in higher education. And that's really kind of an area of interest for me. And I want to basically talk about 4 things that open learning actually helps in higher education. The first one is that we've been looking at equity. We heard Dr. Priscilla talk about access also. And I think having an open learning system enables this, provides that flexibility and that access that people in higher education, as in adult learners, professionals, are actually looking for. The second thing is flexibility. I'll talk a little bit more about our work, our courses, but everybody who enrolls into our programs are working professionals who also have a job and who have families and have other responsibilities. And so there needs to be this flexibility for adult learners in order to actually get the best out of whatever it is that they are training for. The next big relevance is reaching the last mile. And again, we'll get into this in a little bit more detail. But I think open learning systems really enable us to take education to people wherever they are. And so even to get to places where there might not be universities, courses that they want to do, this is something that is very possible through open learning. I also want to say at this point that open learning is also interchangeably used with things like e-learning and distance learning and flexible learning. So those are very loosely or interchangeably used. And then finally, if all of these happen, the relevance for open learning in higher education is that we are able to empower people and thereby transform a community or the society. What about in our country, though? If you read up on this, you'll find a lot of evidence base and a lot of scholarly articles, but it comes out of the Western world, most of it. So the question is, what about in India, and how can we actually make this relevant in our own country? So just want to start by kind of looking at our country. Actually, for about a century, distance education has existed in our country. If you even think about the radio and the television, the fact that a child will watch an advertisement on TV and say, I want that, is actually one form of distance learning. And so it's kind of been around, and some of the education, especially awareness and things like that, have been around through these forms for a long time. But I think formally, really, it was only in the 80s, in 1980, that distance education actually came up as a formal way of education in our country. And the first really big, massive university was the one that is, named after one of our former prime ministers, the Indira Gandhi National Open University, which started in 1985. And actually, IGNOU offers like 300 plus courses, and a lot of people actually choose to take it. But most of these courses are in the fields of art and social sciences and information technology, very few that actually we find in medical sciences, and particularly in medical education. So we still have a long way to go in our country. But in the last 30 years, there are 13 open universities, and these are state universities. These are not central. IGNOU is the central university, and almost 150 distance mode institutions that have been opened. And during COVID, of course, everybody had to do something online. Everyone needed to figure out a way. In fact, even UGC, put out this notice that all the courses that are under UGC, up to 40% of it can be in a distance learning format. And I think post-COVID, we're actually in a time when blended or open learning or distance learning is actually here to stay. At least some component of it is here to stay in most of our higher education portals. Now, the other word that was linked to it was supported. So open supported learning. And here is where I would kind of like to tell you a little bit more about the work that we do, because I think that will really help us to understand what we mean by supported learning. So I have here a picture of our institution. Priscilla had the same one with lots of fancy lights. Mine is a little bit more boring, but This is our main hospital. As you walked in, you would have seen. But here in CMC Vellore, the distance education unit is fairly a new department. We are only 19 years old in comparison to departments that have existed for 75, 80 years. Started in 2004 and started by Dr. Vinod Shah, who is an alumnus of our institution, a pediatric surgeon in training, actually sitting in this room. Sir, I don't want to embarrass you, but thank you so much for being here. And he has worked all over the country in some of the most rural parts. And one of the things that he saw was that we have physicians, we have healthcare workers. He was looking at general practitioners, but I think this basically is applicable to any cadre of health professional. They are there in places where the access is less, but they have no avenues in order to train themselves, upskill themselves, and be more confident in their practice. And I'm talking about lots and lots of doctors in our country who finished MBBS, who don't have an opportunity to continue to do a post-graduation or other forms of learning, but are practicing medicine. So they might have finished MBBS maybe 20 years ago, 25 years ago, and are continuing to kind of work, but really without any kind of support in their learning process. So the whole idea was, how can we take education to them? So this is the mission statement, which says that we focus on training and capacity building for human resource and health at all levels, with a goal to strengthen healthcare delivery systems and primary care research. In India, as well as developing countries, now we have an international family medicine program as well for other Southeast Asian and African countries, to bring sustained health transformation with a special objective to facilitate healthcare access to the poor and the marginalized in the spirit of Christ. So this is our mission statement here in the department. And this approach is through what we call blended learning. And blended learning, as we all know, has two components to it. There is the face-to-face learning and there is the online learning. So the online is where we are able to deliver material for the learner to be able to read from a distance wherever they are. And almost 60 to 70% of the course material can be delivered on this online platform. And of course, today technology in India is so good that you will find that actually people have phones, smartphones, even in the most rural parts of our country. There may not be a toilet, but people will have smartphones. And so actually we can reach material to them, good learning material. But the idea is that it has to be material that actually engages with the learner. It cannot look like our conventional textbooks, because you know what will happen the moment you start reading that at 10 o'clock in the night after a long day's work. So it really needs to be catered to that learner. And so we actually write this material in the form of what we call as self-learning modules. Along with that is the face-to-face interactions, what we call as contact programs, where periodically in the course, we bring our students together and we actually spend a week or 10 days, depending on which course we're running, and able to engage with them in skills and other things that are kind of challenging to do on an online platform. So for us, these two pieces are very, very integral one to another. And both of this together is what forms a good blended learning course. The other thing that we also noticed as we began, our first course started in 2006, and it was a 2-year postgraduate diploma in family medicine, because that seemed to be the need of the hour for the country. Subsequently, we've added several other courses, which I will show you in one of my slides. But initially, for the first 2 years, what we noticed was that the retention rate was not the greatest. Because if you just provide material, but you're not providing the support, a lot of people just kind of fall out of the program. And that's what typically happens in a lot of distance education courses, where you receive material and then you just have to write an exam at the end. But in between, what happens is totally up to the learner. So in 2011, a student support desk was initiated. And really, it was a simple intervention, but has proven to be so useful. Where, first one person, now we have many people, but who are dedicated to following the students, calling them, sending emails, finding out, if they're having any struggle with their assignments or their project submission. And so actually engaging with the students on a regular basis in between the contact programs when we actually see them. And that proved to actually really help. Our retention rate in our courses went up to nearly 90% in almost all our courses, having added the student support desk. And of course, the last thing was that it needs to be relevant, it needs to have a focus on primary care, and it needs to enable a healthcare professional be more confident, because a lot of times the general practitioners feel more like triage doctors. Patient comes and says, I have a headache, get me an MRI, send me to a neurologist, that kind of thing. So how can we upskill them to be more confident and actually refer less and resolve more on their own? So these are the 4 things that I just mentioned that actually provide that support in any open learning program. This is just a quick glimpse of some of our courses. I won't go through them. I won't go through the numbers. The only thing I'd like to say between this slide and the next one is that all our courses, no matter which one it is, diabetes, geriatrics, family medicine, mental health, the focus is on primary care. The focus is really looking at primary care. So, we're not training for people who are going to be working in a tertiary center, but really looking at primary care, because 80% of things can be taken care of right there at the primary care level. So finally, I'm getting to really the disparities. And I've looked at 4 disparities. I'm sure as a group, if we brainstorm together, we'll think of many more. But in the interest of time, I'm just looking at addressing 4 disparities through open supported learning. And the very first one, I think, which is very obvious to us, and we can't not talk about this in a country like ours, is the urban-rural divide, that exists in our country, even today, even, in 2023. So what do we really mean by this in terms of higher education and open learning? This is something that is very obvious to us, all of us know, but this is the distribution of the population in our country. And the numbers may not be exactly right. I'm sure it's off a little bit, but that's the average. And this is really the distribution of healthcare professionals. I put doctors there, but I'm sure it is very similar for all cadres of healthcare professionals. And so you can see that where people need healthcare professionals the most, we have the least number of people. And the higher one specializes, one wants to move to a large city or a big town, because that's really where the jobs are once you specialize further. So there is this huge mismatch, and this actually is something that causes that urban-rural divide to be even greater. The second thing that I want to kind of just talk about when we think about this divide is that if we're practicing in a hospital or even a large clinic, so to say, for that matter, what we actually are seeing is the tip of the iceberg. The patient who comes to us is just one among several. And we know that along the way, some of them receive no treatment, some of them maybe go to the Jola Chap or, a quack doctor. And along the way, we lose so many patients that really what we are seeing is just a very, very small portion. And this was actually drawn by one of my colleagues based on a true story of children who were dying from diarrheal illnesses in a village that she worked in. So how can we basically look at this divide, and what can we do? So like I mentioned before, take education to the doorstep of healthcare workers, wherever they are, because they are not at a stage in their lives now where they can be displaced and come to a place like CMC or any other institution and spend 2 or 3 years training themselves. So how can we actually take education to them? Pardon me for just a second. And one way that we've actually found that this works very efficiently is through a decentralized process. Now, sitting here in Vellore, we have a team of people who create all the course material and run the programs, but we could not do it without these red dots that you see on the map. So these are a list of our network hospitals from our institution, which are our contact centers, and they are distributed all over the country. So when we run a contact program, what we do is actually bring our learners to whichever is geographically the closest place. So like in family medicine, we have 14 centers. So our 300 students in the batch get distributed across these 14 centers. We travel and kind of do the training and the contact programs. They get to see excellent models of care in lower resource settings. Actually, they may be living in that same state or in that same town, but haven't actually had a model that they could actually see and say, I can do this. If they came to Vellore, they would see some fantastic stuff, but it might not be something that they can reproduce in their own setting. And then finally, the other thing is also, we live in a country where state to state, it looks like a different country. And so even contextually, getting health professionals who work in these hospitals, which are our contact centers, to actually engage with them, take some sessions, makes it a lot more contextual for our learners. So this is kind of ways in which we have looked to see how we can address this rural-urban divide. The next one, of course, is gender. And I think the next session is all about gender. So I'm going to touch very briefly on it, but again, something that we need to talk about. So if we just look at a couple of things here, according to the All India Survey of Health Higher Education, it's a survey that happens every couple of years. In higher education, the total number of enrollments gender-wise is 54% men and 46% women. This is, of course, from 2016. Numbers have probably changed now. But across any stream, if you look, women find it more challenging to kind of be there and to commit and do it, although they really want to. Even in any STEM field that we look at, they always talk about that glass ceiling and women can only reach up to that place and can't continue. But how can open supported learning help with that? Now, in an institution like ours, which actually started as a women's college in 1918, the focus has always been that we have to have a good representation of women. So right from our very first MBBS course to every batch that we even take now, there is a fixed percentage, and we've kind of adopted that same value into the open courses as well. And so at least 40% of women learners in every program. And really for women, they are looking to see how they can get back into the workforce. Sometimes maybe finished, but then started a family, had children, have a break, and they really want to upskill themselves. And the flexibility of the course actually allows that. And that is one way that we can address this gender divide. I'm also a geriatrician, as Dr. Addy mentioned, so I can't not talk about age. And I think that's another thing that this course helps, is to actually allow people who are further along in their career. We've had doctors who are ready to retire in the next 2 years, who want to basically do a course in family medicine so that when they retire, they can open a little clinic at home. And these courses allow them the flexibility of that. All right, very quickly, 2 more, and then I'll be done. The professional divide, in the medical field in our country, there is such a hierarchy. The doctor is placed on the pedestal, everybody else is below the doctor. And we're using these courses to try and actually break that, because everybody can have an opportunity to actually learn or to teach. One of my colleagues said a mission hospital where she worked, and she was the only doctor, the staffing was so low. The chowkidar at the gate was trained how to give some health education about malaria and TB to the patients who were sitting there in the OPD just doing nothing, so make some flip charts in the language, show it. So it was actually the watchman who was trained to do that. So really looking to see how can we do that. And I just want to come to that very last bullet point that you see. We run 3 courses now. The third one is lifestyle medicine, which we have just launched in the month of October. But all of these 3 courses have a team approach. So a doctor has to bring in another professional. It can be a graduate from any degree, who will also be trained alongside to kind of support, either the mental health needs or rehab. So we have a mental health worker or a rehab assistant or a lifestyle assistant who's trained with the doctor. And it's mandatory, they don't have a choice. So if they're going to do the course, they have to find another person. And we've had interesting combinations. There's been colleagues, there's been, father, daughter, husband, wife. It's really okay for us as long as they have a required professional degree. And then finally, the access divide, or really what I'm trying to get to this is that the clinic and the community are actually so far away from each other. There's such a wide gap. And we've already looked at that from the point of view of the urban divide, the urban-rural divide. But even access to care is just so limited. So, access linked to geography, access that is linked to economy, not really being able to afford, and then even just awareness. We heard a lot in the previous session about the lack of awareness. And how can we bring this, closer? How can we close this gap between the clinic and the community? And I think really the answer to that, or one way to do it, is to actually empower the community. Everybody need not come to the hospital for everything. Everybody will not have an opportunity to come to a clinic or hospital for everything. So we run community training programs, and I want to focus on two, which is, sorry about abbreviations, but CHPC is basically Community Health Preventers, Community Health Preventers course, and CCMH is a mental health course, so certificate in community mental health. Both of these are meant for volunteers within the community, and we train them in the basics of health. Mainly in the preventive and promotive. We don't teach them a lot of treatments and use of drugs and things like that. But what we hope is that they then are able to pick up the red flags and actually refer appropriately. Or if it is something as simple as a diarrheal illness, teach the family how to make ORS and things like that, or how to check a blood pressure or a blood sugar. Those are the focus areas in these two courses. Similarly, in mental health also, raising a lot of awareness. And then thinking about, can we create a referral pathway with the people we've trained in the community, the health professionals, the general practitioners who have trained in family medicine or other courses? Can we, create a linkage? So here's just a few pictures. One of our trainees who was checking blood pressure out there just under the tree in a village. Somebody else recognizing skin lesions. This is after they've kind of gone through the course or part of the course. Here is someone who is teaching a bunch of children how to do the correct steps in hand washing. So if we think about these people trained in the community, a well-trained primary care physician, and then these decentralized centers that I talked about, how can we kind of link these three to close that gap between the clinic and the community? And I particularly like this picture of one of our centers because, as you can see on the board, it's one of our hospitals, one of our mission hospitals. But it says there that they are in a public-private partnership with the National Health Mission. And I just want to focus here the importance of working alongside the government. I don't think that however good our courses are, we can do so much. But if we want to scale it and we really want to actually get it across our country, we have to link with the government. And we have a couple of programs in family medicine where the state of Bihar, Meghalaya, Orissa now are all sending doctors in the public health system to go through the program. So like I mentioned, how can we link these three to kind of close that gap or bring it close? I don't think we'll fully close it. My last slide here, just looking at all that we've looked at, talking about open distance learning as one model for problem solving. Finally, at the end of it, we want to see how we can actually find solutions to some of these challenges and these disparities in our country. So just, we begin, this is like a 6-step process that one of the articles that I have referenced at the bottom describes very well. But we begin by analyzing, so we do a needs assessment and actually ask that question, saying that needs assessment should ask the question, does this meet a primary need in the country? And then we design the course, a curriculum development to look at all the components of the course, the online modules, the on-site, whatever it is we're doing. Develop that. This is the part, the third one is the part that takes the most time to actually sit down and develop this course, write the modules, put them online, but it's so worth it because once you've done it, then you can keep training year after year. Finally, implement, and student support being very vital there. Evaluate, look at feedback mechanisms, mid-course corrections through the feedback that we get, and outcomes evaluations. I will say that our outcomes evaluation is a place where we need to do a lot more work. Anecdotally, we have a lot of data about how this course has helped a lot of people, but actually look at research in medical education. We're working on that in this coming years. And then finally, make any revisions as necessary, and stay on top of what's happening in medicine and upgrade material, which is easy to do with technology now. So that's it. Thank you so much for this opportunity.
Thank you very much, Dr. Rebekah. I'm sure it's given a new perspective maybe for some of us. Just maybe a minute or two for any questions that are there. Okay, I think that was comprehensive enough. Thank you very much, Dr. Rebekah.
I'd like to ask Dr. Adlin to give the memento to Dr. Rebekah. There are papers that are being passed around. If you have any questions, please write on it and we'll collect it.